Hey folks, welcome back to another episode of The Changed Physician. I'm your host, Dr. Kevin Cuccaro, with my wonderful co-host, Dr. Melissa Cady, and today's fantastic guest, this is Dr. Paul Thomas. Now, Dr. Thomas is with Plum Health Direct Primary Care, of which we are a huge fan of direct primary care at The Changed Physician, and he's here today to talk about his physician journey. So, Paul, thank you for coming on to The Changed Physician.
Hey, thanks so much for having me here. It's really great. Even though it's Zoom, it's good to get together like this.
Well, we're so lucky to have Zoom. Could you imagine if it was like 10 years ago and we didn't have this technology? So
yeah, we'd have to record on a VCR and then mail it to each other, something like that.
Go old school.
Yeah. Whatever they call them, those old telemedicine, or the people use the group calls with the telephone, which are so annoying. But
yeah.
All right. Well, we're in the modern era. We got Zoom. Sure, it's COVID, but we can still connect. And we want to start with your physician journey. And as always, we start with, well, why in the world did you choose this path? Why did you go into medicine?
Well, I grew up in a Methodist church, and I was looking for ways to volunteer in the community. And there was something called Cass Clinic, which was affiliated with Cass United Methodist here in Detroit. And so I started volunteering at their free medical clinic for homeless and uninsured folks and elderly senior citizens who had transportation issues. There's a senior citizen center down the street. There was a Mariners Inn, which was kind of like a halfway house or like a drug rehabilitation program. And then there were a lot of homeless folks who came through. And I got to volunteer as a high school student at 17, which is really transformative for me. And I got to work shoulder to shoulder with Wayne State University School of Medicine medical students, and then a preceptor named Dr. Costia, who could handle seemingly anything that walked through the door, and a lot of interesting things walked through the door. And so that was super inspiring, and it changed my worldview, and it changed how I thought I could impact the world. And I loved being able to get to know people longitudinally, like over multiple visits. And then I really enjoyed that relationship building and the camaraderie among the students. And so I was like, okay, I want to be a doctor and I want to go to Wayne State School of Medicine.
Wow. So pretty early focus then. I'm assuming if this is high school, you knew where you wanted, I'd have to go to college, and then you're making everything ready to go to Wayne State. So how was that sort of trajectory? Did anything kind of derail that, or were you pretty laser focused for that part?
I was pretty laser focused for that part. I went straight through. I went to Michigan State, had a wonderful experience there. Largest land grant college in the United States, known for the Spartans and the beautiful school grounds. It's a great place to be. And then right after that, I matriculated at Wayne State and started immersing myself in the Detroit community, volunteering at places like Cass Clinic. My first year, we started a student-run free clinic on the east side. Cass is kind of like in the downtown, midtown area. On the east side, there was not a lot of healthcare resources, so we started our own clinic over there. We also, my junior year, we started this thing called Street Medicine Detroit, where we'd go out and deliver healthcare to homeless folks on the street, in parks, on street corners, in homeless shelters, like in the basement of a church, et cetera. And then we also did this really unique art project where we built an outdoor medical clinic at an outdoor art center called Heidelberg Project. And it was like a physical representation of a clinic that should be there, but wasn't because of disinvestment and a lot of other systemic factors. So Wayne State was just this an amazing place to learn about medicine and the community and invest in that way.
Awesome. Wow. That is super inspiring. All the things you did just in that amount of time. I'm curious. Well, first of all, that just where you kind of created, if you can go extend a little bit more, I'm kind of curious what they did based on that art exhibit type infrastructure.
Sure. So there's this artist named Tyree Guyton, and a lot of people left the neighborhood. A lot of buildings were burned down or demolished in his community, but he stayed. And then he started collecting car hoods and tires and stuffed animals that were discarded. And he made all this amazing artwork, even boats on this 3-block area, 3 entire city blocks. And then we asked him if we could build a medical clinic, like an outdoor medical clinic, to represent, what could be in that neighborhood, but isn't because of all these different factors? And he said yes, which was really surprising. So we were like a group of 10, 15 medical students. We bought a bunch of supplies. We got some old exam tables, an old desk, old radiology images. And then we built this like outdoor clinic thing, and it got picked up by like the Detroit Free Press. And like there's a art blog that I used to follow, this is like late 2000s, late aughts, as you would say. And it was like this really cool thing that we made, and it's still there. And it's been like weathered and changed over time. And he's added like different elements to it, but it still exists. So it's a neat place to go.
So did that inspire any other kind of like resources for the area, or what did that lead to?
Well, I mean, for me, it was kind of like emblematic of the clinic that I wanted to build when I graduated. And so I ended up building a clinic that was not unlike that clinic, just down the street. So like we're, a couple miles away here in Corktown from where we built that at the Heidelberg project. And my initial office was quite similar to that outdoor office. It was just like one exam room with a desk and an exam table. And that was like what my office was when I first started this direct primary care practice. And now we have this like 1,700 square foot facility with 3 exam rooms and, med room and supply room and all that. So it's a little bit bigger, but for me, that's kind of like an anchor of like in my mind's eye of like what's possible with some intentionality.
Yeah. So you were going into your training for primary care. You'd kind of chosen that path, and it's pretty traditional training. Was there anything about that training that surprised you and how medicine was being delivered?
Yeah. I talk about this in my TED talk, but, like I really loved that time that I had with my patients in medical school. And then the further and further I got into residency, and by the time I graduated from residency, I just had less and less time, where I would really only have 15 to 20 minutes per patient to see them and take care of them. And I thought that was like a dreadful amount of time. It just wasn't enough time to give my full time and attention to somebody. When I talked to the previous graduates, great doctors, really good people, but they're just trapped in a system where they have to see 25 patients, 20 to 30 patients a day. Some of the high producers, see 40 patients a day. And, they make a lot more money because it's a volume game, and we're incentivized in the fee-for-service system to see as many patients as possible. And I totally rejected that notion of like, yes, let's see as many patients as possible because that's great medicine, because it's not. And, medicine for me is all about developing strong, caring relationships with my patients, and it's bi-directional. My patients care about me. They ask how I'm doing, which didn't really happen when I was in the system. Or, my first year out of residency, I was working in urgent care, I would see 40 patients in an 8-hour shift, and sometimes 55 to 60 patients in a 12-hour shift. And that was like what was expected. And I hated that. And I just was like biding my time until I got a more full panel at Plum Health.
Yeah.
So that's kind of interesting, because you went, you had this mission pretty early on in high school, and it sounds like you're pretty laser focused. You're still dedicated. If you have this kind of physician mentality, or I'm going to care for people, and you maintain that through residency, which I think sometimes gets lost in a lot of us. But when did the idea of changing your model, like direct primary care is much more known now than it used to be. I'm certainly at the end of the early aughts, it was really pretty still new then. I mean, there was a couple kind of people at the forefront then, but it was not as widespread as it is now. So when did you decide, because some people would say, well, I'm going to change my specialty. I'm going to go into this. I'm going to leave medicine. Why did you then decide I'm going to change the model through how care is delivered?
Yeah. So like 2012, my friend who's like a libertarian sent me this podcast, and he was like, oh, you got to listen to this libertarian doctor out West doing this DPC thing. And I was like, oh, cool, man. I listened to it and I thought it was really cool. The guy was super passionate, but I was like, oh, I graduated med school in 2013. So I was like, I'll probably like work with the hospital system and be like professorial and teach other residents. Like that's kind of like the vision I had for myself going forward. But then at the end of residency, at the end of like, mid 2016, I was like, there's no way I can do this, really at the end of 2015. And then in March 2016, I had like a practice management, and I wrote a business plan for my direct primary care practice through that practice management. The assignment was write a business plan for a fee-for-service clinic, but I was like, no, that sounds terrible. Let's do one for a DPC office. It was super simple. I explained it all to my co-residents, and all the light bulbs went on. They're like, oh, that is simple. And then I wrote like a curriculum for myself. We could do an elective in our final year of residency. So I did a direct primary care elective. I wrote a curriculum that I'd spent 2 weeks with DPC doctors, and then just read, X, Y, and Z about it, and then write a little thesis at the end. And so I did that. I drove out to Denver, Colorado area, and I spent some time with Dr. Flanagan. And then I went out to Wichita, Kansas, and spent some time with Josh Umbear and the Atlas Clinic, and just learned a ton from those guys. They looked over my business plan. I really took the best of what they were doing out there and brought it back to my practice here in Detroit, and we've succeeded with it. We've tweaked it along the way, but the formula works. The business plan works.
Yeah, that's awesome. Kevin, do you have another question?
I have many more questions, but I don't want to
No, you go ahead. I've already stolen a few. Go ahead.
Well, I just love that, because we've had Josh on the show, and I'm looking at your website and listening to your story, and it's interesting because his story is a little bit different, but the passion for medicine is still there. And he approached it from a, much more of a libertarian mindset of how do you deliver effective, cost-effective care. And what I'm hearing in what you said is this focus on really how can we provide great service to a population that needs it, that is interested in an underserved population. So when you were creating your business plan, did you anticipate then, where you because you said your office now is 2 blocks away from where you had built the I don't know what you call that, the art clinic?
About 2 miles.
About 2 miles away. But were you anticipating moving in toward an underserved area, or trying to create affordable care for perhaps people that were having difficulty finding good care?
Yeah, of course. I mean, all of Detroit is medically underserved. Our clinic is in an HPSA, or a health professional shortage area. So there's about 50, probably like 75 to 100 primary care physicians in the city of Detroit right now. And there are 630,000 residents. So there's about 1 primary care physician in Detroit for every 6,000 residents. And an adequate number would be 1 physician for every 1,800 residents. So that's more than 3 times underserved. Now, the contrast is, if you just go north of 8 Mile into Oakland County, one of the wealthiest counties in America, I think it's like top 5 wealthiest counties in America, there's 1 primary care physician for every 600 residents. Then if you go west, over to Ann Arbor, same thing, 1 primary care physician for every 612 residents, or something like that. So there's a 10x disparity, 1 to 6,000 versus 1 to 600 in the Detroit community to the surrounding communities. And so I'm acutely aware of that. And a lot of Detroiters have trouble accessing excellent primary care services, because even though they might have health insurance coverage, it doesn't necessarily mean that there's a doctor in their community that can see them. And even if they have to drive north into Southfield, which is in Oakland County, and see a doctor there, they may not reliably be able to make that trip, because about 35% of Detroiters don't have access to reliable transportation. So for us, it's instrumental to be in the city, to be on a major route. Like, we're right on Michigan Avenue, really close to the Rosa Parks Transit Center. So we can capture people who might have to rely on a bus to get to our clinic, or might have to walk to our clinic. And so that was super important for us to be in this urban environment, and to be able to serve people who don't have access to healthcare. And that's our mission statement. We believe that healthcare should be affordable and accessible for everyone. And that's what we're trying to accomplish with our clinic.
Yeah. How do you describe to people that don't understand what direct primary care is? What's your spiel?
The short version is, it's concierge medicine, but for everyone else. We have that mentality that every single person is super important. And, you have our cell phone numbers, email addresses. If you text me, I'm going to respond pretty much right away, at least within 24 hours. However, we don't bill or use insurance. You don't need to have insurance to be a part of our clinic. And it's $50 a month. It starts at $49 a month for adults, and it's $10 a month for kids. And so if you can afford a cell phone bill for yourself, you can afford direct primary care for yourself. If you can afford a cable bill for yourself, you can afford excellent primary care services for your family through this DPC model.
And how would you describe to people how you make, like, whether it's prescriptions or labs, or how would you describe how that becomes affordable for people?
Sure. We get all our meds at wholesale, and we save people 50 to 90% on the cost of prescription meds. We do the same thing for lab work. We contract with Quest to get the best prices possible. For example, if you want to check your cholesterol at my old hospital system, that would be $150 to your insurance. And if you're uninsured, it'd be $150 too, because that's the price. At our clinic, it's $6.
Yeah.
And I think this is where the health insurance system, like the health insurance hospital industrial complex, really screws Americans over, because if you make too much to qualify for Medicaid, but not enough to afford private health insurance, you get stuck with the hospital-based charges that are super inflated because they assume that there's going to be some sort of hospital discount or insurance-based discount. But if you're uninsured, you don't have the luxury of that discount, and you're paying full freight, which is a really unreasonable amount of money. So basically, if you want to get your annual labs, you're billed $500. In our clinic, it's $31. So it's a huge difference in terms of affordability. And then I am sorry if I'm going on a run-in here, but
please continue.
We
love it.
The really important thing that our clinic does is that it empowers people to take care of themselves. So if you're looking at managing diabetes, maybe you are buying all of your diabetic meds at the pharmacy for $150 every month. You were seeing a doctor every 3 months for $150. And then every 3 months, you needed a hemoglobin A1C for $150. So, average out monthly, that's about, $250 a month, versus in our clinic, it's $49 a month for your membership, plus $6 every 3 months for that hemoglobin A1C, plus maybe $20 for your diabetes meds, because we get you insulin for free here through like our industry partners, Novo Nordisk, Novo Medlink, free diabetic supplies and all that kind of stuff to help our patients. So, that takes somebody from a place where they're not even checking their numbers because it's going to be too expensive, to somebody who's amped up about, hey doc, I was 100, my blood sugar was 100 this morning when I woke up, and they're like writing all of them down and bringing them to their next appointment, proud about the progress that they're making.
Yeah. And sorry, I was just going to, just to clarify for people listening, when you say the price is like you're drawing the blood there, you're giving the medicines to them directly there. They don't have to go anywhere else to get those things. It's
exactly.
like a one-stop shop. So anyway, sorry, go ahead, Kevin.
Well, and
exactly.
I was going to compound onto that too, is because we have all this stuff about non-compliant patients and this, that, other thing. And that always irritates me, because you're like saying that people choose to be sick. And it's like, that is so wrong to do. Mm-hmm. And you've created this model now where you can deliver fantastic care at a really, really affordable cost. And the other thing that you again mentioned before is you're not doing this on volume. So now you have the time to spend with these people, and it sounds like they're engaged with you. Like, so I would be kind of curious, how is your, in residency, it tends to be very busy practice. When you were in urgent care, it was very busy practice. But how do you see your interactions with your patients now, and how engaged are your patients when it comes to follow-up care, when you are giving them recommendations and coaching them on what to do? What is that like in your practice?
Yeah, sure. The average doctor has 2,400 patients. The average primary care physician has 2,400 patients, and they have to see 1% of their panel each day. So that's about 24 patient visits a day. In my model, our physicians cap around 500 patients. Right now, I'm around 480. And so I see about 1% of my panel each day, which works out to be about 5 patient visits each day. That allows me enough time to spend an hour with each patient if I need to. Most visits are 30, 45 minutes, sometimes an hour, and really fully listen to their concerns and come up with a treatment plan that we can agree on and something that they're going to follow through on. And then I hand them the meds on the way out the door so that they're able to take them. And then I can set reminders in my calendar like, oh, I just started this patient on an antidepressant. Let's meet up in 3 months. And then I'll put a little reminder in my calendar to follow up with them in 2 weeks, just to make sure they're not having any side effects from the new med and things like that. So I can, go through those check marks for my other patients during the day. I have maybe 4 to 5 hours of patient care time each day, and then 3 to 4 hours of admin time where I can run through those check marks, where I can text my patients who are trying to quit smoking or lose weight and give them some encouragement, and then make the phone call follow-ups on somebody who saw a specialist and what was discussed and all that kind of stuff. And it just feels a lot more natural, where I'm not so pressed for time running from room to room, where I can really just like enjoy the interaction and the process rather than just constantly feeling rushed and stressed all day. It's a pretty good feeling.
And I'm laughing because you're like, oh, I have my 4 to 5 hours of admin time. And I want to make sure that the listeners understand that, because in a traditional practice, when I'm doing administrative tasks, it's usually after the end of seeing their 24 patients a day, they're doing the 2 to 3 hours of administrative tasks, which is, filling in this junk and doing all the stuff. Your administrative task in that 4 to 5 hours sounds like it's actually doing useful stuff, like and checking in on
patient care. And
patient care. Yeah,
that's what I hated about the EMR and the system. It's like you're checking all these boxes that don't mean anything for your patients. In my model, I'm following up on things that are important for patient care and how they're experiencing their healthcare and how they feel. It's funny you bring that up. There's a statistic that every primary care doctor spends 86 minutes every night doing what's called pajama notes, or those administrative tasks after hours. So like they go home, cook dinner, or, get some takeout, put the kids to bed, read a bedtime story, pour a glass of wine, and then do an hour and a half of additional work every night. And I've had the luxury of not having to do that, where I can really just focus on taking care of my patients during the day and then focus on relaxing, recharging, reading, being better for my next day, for my next patients.
Yeah, I love that. It just so much, I don't know, it speaks to me because it's fun. I'm not in primary care, but when you can create the experience and make it for the benefit of your patients, there's nothing better than that if you're in this field for the right reasons. So I just want to thank you for that. I wanted to give you a chance to, I know Kevin wants to ask you this question, but maybe I'll ask it. Why did you name your business Plum Health, and let people know where they can find you too?
Yeah, Plum Health, it's a direct primary care service. For me, the plum is like a symbol of 2 overlapping circles. If you were to draw a plum, you just do like 2 overlapping circles. And for me, that's like the doctor-patient relationship. And that's why we chose Plum. And it's just a nice sounding name. It's like Plum Health. It's nice round sounding. And people sometimes say like it's plum, like if it's square, if you build a building and it's square or something. And then also it's just, every large medical institution in the healthcare industrial complex in our community is has a blue color and is eponymous for a man. So we have St. John Ascension, and we have William Beaumont Hospital, and we have Henry Ford Hospital, and we have like Hutzel Hospital and Carmanos Hospital. And it's just like, come on, guys, can we like spice it up and get, we have a nice purple color here. And then, it's just kind of a little bit more feminine, I guess. And then, we're welcoming of all people of all walks of life. So we take care of a lot of people, and the majority of our patients are in minority communities, meaning they're either ethnic or religious minorities or LGBTQ plus, et cetera. So that's a really cool place to be as well.
Wow.
And I just want to read because I looked at your pricing sheet, and this is the thing that I just want people to really understand, because you mentioned it already, But you look at the membership model and fees, and it's ages 0 to 17, $10 a month, 18 to 39, $49 a month, 40 to 64, $69 a month, and then over 65, $89 a month. And, for that, having access to your physician, having, the ability to get medications that's significantly lower than what most people are getting, this is a model that anybody can do. So, again, thank you so much for bringing this and bringing these to communities that really, really need good care. I mean, it's astounding and just so appreciative to see doctors doing wonderful work and choosing not to accept the models that everybody thinks that they have to take.
Yeah.
Yeah. It's 2020. You don't have to sign with the big hospital system. You can do something unique, whether it's direct care, concierge medicine, telemedicine, and there's so many unique ways to earn money now. So it's like you can write books, you can be a podcaster, you can write blogs. There's just a million options. And if you're burned out on medicine, maybe take a break and do something different.
Yeah. Well, just to reinforce, the website that Kevin was looking at is plumhealthdpc.com.
Oh yeah, our website, plumhealthdpc.com. And then, I'm on Instagram and Twitter as well at those same spots. So at Plum Health DPC on Instagram, follow us. We got some cool content every day. We tell some good stories. And then we're also on Twitter. You can reach out on LinkedIn as well. And then, as a side project that I did, I've written 2 books. One is like explaining our model. And then the other one is for doctors who want to start this sort of thing themselves. It's called Startup DPC. How to start and grow a direct primary care practice. So I'm going to plug that as well, shamelessly.
Go ahead.
Going to throw it up here too.
Love
it. This is another thing that the practice allows me to do, things that I really enjoy doing. I've always loved writing. I've always wanted to be an author, and it's cool to have like some downtime where I worked on the book like 2 hours each week for, 12 weeks or something, and I had a nice book out of the deal. So it's a cool spot to be able to leverage my time in different ways.
Yeah. Was that self-published or just curious?
Yeah. It came out really professionally because I know a publisher. He's actually somebody in my inner circle that I met through starting my practice. And I was just talking one day about like wanting to publish a book. And he said, "Oh, I have some experience with that." So I sent him the manuscript, and one of my patients is a photographer. He took a couple photos of me for the cover, which was cool. And it came out really nice. But yeah, it's just self-published on Amazon through, that's called KDP, Kindle Direct Publishing.
Yeah. Excellent. Strong work.
Thank you. It's a fun one.
Yeah, that's great. Yeah, freeing up your time for the things you love. That's the beauty of designing your own, business and life. So, and we are definitely time stamping COVID right now with your lovely mask. So, very nice. Kevin, any last questions?
There's so many more things I could ask questions about, but I'm going to respect your time, Dr. Thomas. And it looks like you got people in the clinic now, so I will.
Yeah, we just had somebody come in for the last appointment slot of the day. So
perfect. Well, that'll be our exit. Kevin, unless you have anything else, I'll take us out.
Take us out.
All right. Well, again, I'm Melissa Cady. I'm here with the Change Physician podcast and community with my co-host, Dr. Kevin Cuccaro, and our amazing direct primary care guest, Dr. Paul Thomas. I'll put all the links in the YouTube video area so you guys can follow him on all the various social media outlets and find his books and whatnot. So until next time, everyone take care. Bye-bye.
Stay well.